Hello everyone and welcome to Epilepsy Research UK's Innovation in Healthcare Awards Night webinar. My name is Quiva Bennett and I am Head of Research at Epilepsy Research UK. We've got a fantastic lineup of speakers this evening. We'll be hearing from researchers who have recently been awarded funding for an Innovations in Healthcare research project, who will also be answering some questions that have been submitted by you, our supporters. We will hear from Professor Markus Reuber, who is a Professor of Clinical Neurology at the University of Sheffield, as well as an honorary consultant at Sheffield Teaching Hospitals NHS Foundation Trust. And we'll be joined by Markus's colleague Jo Ford, who is a conversational analyst later on in the session. We'll also hear from Professor Sameer Zuberi, a consultant paediatric neurologist at the Royal Hospital for Children and honorary professor at the University of Glasgow. Finally, we will hear from Dr. Rhys Thomas, who is an epilepsy neuroscientist at Newcastle University and an honorary consultant in epilepsy at the Royal Victoria Infirmary in Newcastle. But of course, let me introduce our host for this evening, Andrew Peaple. Andrew is a former journalist who now works as a director of research with the UK-China Trade Group and also co-hosts a podcast on Asia. Andrew's family experienced the tragedy of losing his sister Claire to sudden death from epilepsy in 2002, when she was just 25. Andrew, who was working in Tokyo at the time, has since lived and worked in Beijing and Hong Kong, as well as London, but is joining us today from the village in Kent, where he now lives with his wife and 4-year-old son. So, Andrew, it's over to you.
Thank you so much, Quiva, for that introduction. And hello, everyone, and welcome to this Innovations in Healthcare Awards evening. I'm absolutely delighted to be here to host these awards, which, as Quiva said, is for a charity, Epilepsy Research UK, which is very close to my heart. Well, the COVID-19 pandemic has caused considerable challenges in the way that people with epilepsy are able to manage their condition and how health services provide support for assessment, diagnosis, and treatment. The speed at which health services have adapted during the pandemic shows that change can happen quickly if people focus their efforts to solve an urgent problem. Epilepsy Research UK saw an opportunity to build on this new openness to change and to drive the development of new innovations for people with epilepsy at this time. Epilepsy Research UK has funded 3 exciting projects. And this evening, we'll be finding out how each project has the potential to revolutionize health services for people with epilepsy. So as Quiva introduced earlier on, we'll first be talking to Professor Markus Reuber, who'll be discussing his Innovations in Healthcare research project, which is co-funded by Epilepsy Research UK and Epilepsy Action, to compare interactions in remote and face-to-face seizure clinic consultations. Well, congratulations to you, Markus, on this research funding, and Jo as well. And we look forward to hearing more about the work that you've been doing in the presentation that you're now going to give. So I'll hand over to you, Markus, and congratulations again.
Thank you very much for the introduction, Andrew, and to Epilepsy Research UK for the opportunity to talk to people about the work that we intend to do. So I'm just going to call up my presentation. So I will, let me just quickly zoom back. All right, here we go. I will spend 8 minutes talking about the plans that we have for our research. What we're planning to do is we are planning to compare interactions, so talk in remote, that is telephone or video phone consultations, and face-to-face seizure clinic consultations. And this is going to involve me and Jo Ford, conversation analysts. So why would we want to do this work? Here's some photographs of the past, present, and perhaps future of communication. You may be familiar with the typical clinic setting as it used to be. I've always greatly valued listening to patients. I've stressed the importance of listening to patients and taking account of their views. I've written extensively about the importance of doing that to put the doctor in a position to deliver good healthcare. The middle picture shows me doing the same sort of clinic that I was doing on the left now. So we sit there, we have to manage several pieces of software to get information from previous correspondence, from blood results, from brain scans. We have to integrate all this whilst trying to concentrate on what the patient is telling us. Usually we can't see the patient, or we can only see them by video phone. It's even worse for those patients in some ways who come and see us in the hospital. They would encounter me looking like I am on in the picture on the right, in full PPE, which thankfully we now have, but which is not a great facilitator of good communication. For instance, you can't see my mouth, and it's difficult to understand what people are saying, especially if they have hearing impairments. So why should we be interested in communication? Communication is what doctors do. I know we do a lot more. We give medicines, we operate on people, but underpinning all this is communication. Now, how should we do it? The GMC tell us how to do it. The NHS Constitution tells us how to do it. Here are the 7 principles of decision-making and consent, which the GMC has just published this month. And you see that all these principles absolutely stress the importance of listening to patients, of involving patients in decision-making. You know, we should get them involved. We should support them. We should know that decision-making is an ongoing process. It doesn't just happen at the first visit. Patients have a right to be listened to. Doctors need to find out what matters to patients if a choice is to be made. What are their priorities? Doctors have to presume that patients have the capacity to help with decision making. They can't presume that they can't, and doctor knows best. And if patients do lack capacity, as of course some individuals do, then we should strive to communicate with others close to them, or people who can talk for them. And even if patients' right to consent is reduced, we need to support them in decision-making processes. So we know what we ought to do. What the GMC don't tell us is how to do it. So how do we do this in the age of COVID? We've conducted this qualitative study where we interviewed 30 neurologists about their immediate experience with teleneurology shortly after the wholesale switch in March from face-to-face encounters to telephone encounters. And there were sort of 4 themes that came up. The most important one actually was the unknown theme. This was to do with the doctor not being able to examine the patient, but also, importantly, missing out on non-verbal communication. Doctors on the whole were, however, surprised that there was quite a lot they could do over the phone. So the better services team recognized that it was actually quite easy for patients, and easier than coming to the hospital, sitting in a waiting room, and eventually seeing a doctor. Patients were often less stressed when they could speak to the doctor in the home environment. And because there are actually quite a lot of positives, it was widely appreciated that this form of communication will never go away. It will continue beyond the pandemic. However, there were these obvious challenges with not seeing people. And at that point, most of my colleagues, or many of my colleagues, thought that video might be the answer. On the other hand, they appreciated the challenges with video. So there are still many technical challenges, quite apart from many patients not having access to the necessary equipment. Even in the hospital, we don't have access to the kind of infrastructure in terms of bandwidth that allows uninterrupted communication. Sorry, I was showing you what often happens and was particularly annoying in the middle of a consultation. So there were goods and bads that came out of this. I'm not going to run through this whole list in the 8 minutes. the main positive thing was that actually a lot of decision making could be made, and that it was easier for patients to access conversation. On the other hand, there was the worrying feature that consultations seemed more efficient, shorter. So what's missing in consultations? And then there were the negative aspects of lacking non-verbal communication. So what we want to do is we want to examine exactly what these telecommunications look like. And I've already shown you the team. You'll have an opportunity to talk to us later. And we'll be doing this using conversation analysis, which is a method to study interaction. It was originally used to study how people apologize, recommend, or complain about things. It was used to study naturally occurring interactions, but it has recently been used to study medical interactions and to answer medical questions. It is a very fine-grained technique. So it builds on one of the fundamentals are that if you say something, then you are restricting and shaping the answer options of the next person. So as communication develops, the way you say things will have an influence on the next turn, which will influence the turn after that, and so forth. So sequence is very important. The simplest examples of this are so-called adjacency pairs, like a greeting provokes a greeting, a question and answer, a proposal and acceptance or rejection. And in this way, you can also study more complicated things like misunderstandings, how they arise, how they're cleared up, whether they're noticed. And that's something that we particularly look for to try and detect what's missing in these telephone conversations, what makes them shorter, and how we can optimally involve patients in decision making. Now, we have the advantage of building on this body of work that I've carried out previously, over 200 encounters face-to-face that we recorded for this study, where we evaluated decision-making practices in neurology clinics. About 50 or so of the encounters in that study were in seizure clinics. So we know what happens in face-to-face interactions, and we will look at what happens in telephone interactions and describe the differences and draw lessons for doctors. We're very grateful for Epilepsy Research UK and Epilepsy Action who've made this possible. And of course, we're grateful to people who've donated to these charities as well. I'm very pleased to have an opportunity to talk to you about our study afterwards. So thank you very much for listening. I hope I haven't overrun.
No, and thank you, Markus. Absolutely fascinating presentation there. Just a quick question from me. Where will you take this research next, do you think?
I'm currently putting together a teaching platform, an online teaching platform, building on the lessons from our previous face-to-face project. The GMC guidance is new, it's just come out, and it says that the patients have a right to be listened to. This is binding for doctors, it's not something we can do or not do. This is what we must do, but we need to know how to do it optimally, and that is not straightforward, because you have the basic problem is that in medical interaction, you've got a doctor who knows a lot, and you've got a patient who needs to know stuff to make a decision, and it's very difficult to communicate the knowledge without actually making the decision implicitly for the patient. To really give patients an optimal choice, to equip them to make that choice themselves, is a challenge. And that's what we're trying to do. And I think it's an even greater challenge over the telephone, where the risk of misunderstandings is greater. So absolutely. I think, we talk about putting together teaching packages. And of course, as part of this project, I forgot to mention, we also interview patients afterwards to find out how happy they were with the encounter. So we can contribute the patient's view, and we can actually demonstrate what happened in the encounter, and not just say what people should do, what's good in theory, but we can show what happens in practice.
Thank you for that again, Markus, and congratulations on this award. We'll hear more from you later, hopefully, with our roundtable discussion. But for now, thank you so much. We're going to turn now to Professor Sameer Zuberi, who will be talking about his innovations in healthcare research project, which is to evaluate a new clinical service to allow video sharing and remote care for people with epilepsy. Congratulations, Sameer, and I'd like to hand over to you now to give us a presentation and an outline of the work that you've been doing.
Thank you, Andrew. So I'm just going to share my screen now, and I'm going to tell you about a project that we've developed through COVID, but has actually had its genesis before that time. So this is about evaluation of a new clinical service to allow video sharing and remote care for people with epilepsy. And I'd like to thank Epilepsy Research UK and all the fundraisers that do so much wonderful work for the charity, for the opportunity to do this work. So this seems like a very simple idea. We've established a cloud-based system with our technology partner called vCreate, where families can take videos on their smartphones of a seizure, of an event. They can upload it through a secure system, send it to a cloud-based system, which a doctor, a clinician, a nurse specialist, a neurologist can view and then can comment on, classify, and then communicate back with the family. So this, I'm speaking on behalf of a large group of individuals from 15 different centres around the UK, and particularly in Glasgow, my colleague Neil Patel, and also some specialists in machine learning and artificial intelligence, Professor Trucco and Professor McKenna in Dundee University, and also colleagues from Healthcare Improvement Scotland. So this project had its genesis actually in a neonatal unit in 2016. A father who had a baby in the unit, and this father manages a car dealership in Glasgow. And his baby had been in the unit for a long time. He couldn't always be in the unit. And he said to my colleague, Dr. Neil Patel, "Can you send me videos of my baby when I cannot be in the hospital?" Where what he did for his clients in his car dealership, he gets his mechanics to take videos of the car being serviced, and it gets sent back to the client. So Neil found Ben Moore, who is the founder and CEO of vCreate, which is a video company who'd just been producing commercial videos at that time. And they set up a way of nurses being able to take videos of babies in the neonatal unit and then sending them back to the parents. And as you can imagine, this has been really successful. But the key thing about that was that it's a secure video system on a platform which has all the information governance approvals that you need to be sending medical images. Now in neurology, we have struggled for decades as to how we get videos from our patients. But we know that our patients bring in videos to us. They bring them in person via email, they send them via WhatsApp. But we don't have anywhere to secure them securely and look at them. So during the pandemic, we managed to put a successful application to the Scottish Government Technology Enabled Care to establish the vCreate Neuro system. So we use the same platform that they've used in the neonatal unit, but we send the videos the other way from the families to the clinician. So this pilot began on May the 1st, 2020, and now it involves all adult and pediatric neurology centres in Scotland. Now it's moving into district generals, and it's moving also now into some English centres who came on board in November 2020. So I'm going to show you the system through the wonders of medical technology. I've now moved to my browser. So this is the vCreate system, just to show you very quickly how this works. So from my side, I go into it, and it's a bit like online banking. And similarly from the side of the patient, and I hope that my nervousness means that I've got the correct, yes, there we are, I've logged in. So this is a cloud-based system. So when we have a patient, we can invite them to become a patient on the system, and we can invite them to the epilepsy and paroxysmal disorders. And I've also now established a movement disorders pathway in this. We also get their postcode, and then we invite them to register for the system. The patient gets an invite on their mobile phone, and then they register. And then once they're registered, they can upload a clip. And I get an email message saying that the clip has been uploaded. So I just want to show you what a clip looks like. So this is from a patient in the height of the pandemic. This is a family that live about 100 miles away from Glasgow, and they sent a video of their baby having these events. And you'll see this just in a moment. And I can look at that and I can say that's an infantile spasm. Now, almost immediately, that day, we got the baby up to Glasgow, did an EEG, started treatment. A few weeks, and the baby was treated successfully. A few weeks later, the family came back to us and said, our baby's having other episodes. We're worried that the spasms have come again. So we said, okay, can you send another video? And this is what we see. The baby's just having little scrunchy faces, which is completely normal. So what we can do in this system is we get the answers that the family has written. So they write a whole lot of information before they upload the video, which we can look at, and then we can classify the video. So we can classify the clip as to whether we think it's epileptic, and I say it's a spasm, and then I can look at the etiology and I can say what type of etiology it is, and I might suspect it's genetic, and then I can add a note. And I've got all this in my system. So this is all within a web-based, cloud-based system. And it also allows me to subsequently, I'm just going to go back now to my PowerPoint, to share cases, share videos with other families. So this has been very successful. We've had 2,500 videos uploaded, primarily in Scotland, 1,000 within our own service in Glasgow, and now other services, Great Ormond Street, Sheffield, Evelina coming on board. I just heard today that Evelina had uploaded 28 videos. So these are some of the messages we're getting back from the families. So they feel reassured. They feel that they've got better access to the clinical team. They find it much easier to use and transfer us information than trying to send us an email. Our secretaries find it easier because they're not dealing with lots of emails. Clinicians think this is easier because they can see the videos. It allows them to assess, make a diagnosis much more rapidly. So what this research funding from Epilepsy Research UK will allow us to do will be to assess all this information, to see what benefit the system is having to families, to clinicians, to look at the economic benefit in partnership with Scottish Government. And also, alongside the clinical system, we're establishing a research database. So the vast majority of our families are consenting for their video to be put in a neurology video research database. And I had the Research Ethics Committee meeting just a week or two ago, and I got lots of thumbs up at that meeting, and I'm waiting for the official approval. But what we can do now that we're potentially in the next year having thousands of videos is we can do machine learning. So with machine learning, which our colleagues in Dundee will do, we can perhaps diagnose seizures automatically in the future. And can you imagine what benefit that might have globally in epilepsy diagnosis? So we know 50 million people in the world have epilepsy. Only 1 in 4 people with epilepsy are treated, but 70% of people could have seizures controlled on medication. And a lot of that medication is incredibly cheap. We know that misdiagnosis is common, and we need to reduce the worldwide treatment gap. So a system like this only needs a smartphone and an internet connection and a clinician with knowledge of epilepsy. So we thank Epilepsy Research UK for the funding to allow us to evaluate this further. And I'll stop my screen share.
Well, thank you so much for that, Professor Sameer. That absolutely fascinating. And as you said, such a simple idea, and yet so many implications in a way. And the way you talked about how machine learning can be used with this going forward was fascinating. And presumably this is something that was spurred by the pandemic, but you very much expect to be part of the way you deal with patients going forward.
Well, interestingly, we decided we began to develop it before the pandemic.
Right.
So we began to develop before the pandemic, but we had put a couple of applications in, but couldn't get any funding. But the pandemic came along, and then suddenly people saw the need for asynchronous video.
Yeah.
And then we got the funding from Scottish Government. But this is really transformed our clinical practice. So we will keep this long term.
Fantastic. Well, thank you. And congratulations again, Sameer, on the award this evening. We're going to turn now to Dr. Rhys Thomas, and Rhys is going to be talking about his Innovations in Healthcare research project, which is on reducing holistic epilepsy risks during the COVID-19 pandemic. So, Dr. Thomas, if you're there, I'll hand over to you now, and please tell us more about the work that you've been doing.
Thank you very much for that kind introduction. So you'll find a couple of similarities or themes perhaps between the three presentations tonight. I think perhaps one is about communication and one is about trying to make sure that we, what's the phrase, build back better, that everything we had to change for the pandemic, we keep the best of. So one of the things we do in epilepsy is probably not unique to epilepsy, is about managing risk. And that could be risk of seizure, it could be the risk of injury following a seizure, it could be the risk of giving too much medicine, not enough medicine. And one of the most serious risks that patients worry about and clinicians worry about is a risk of sudden death associated with epilepsy. And under the best of circumstances, we balance these risks. But when everything changed this year and we had to go to distance consultations, primarily telephone consultations, some video, we were really concerned about what Markus described as the unknowns. What risks were we missing? What couldn't we see? Were we still dealing with risk as well as before? So the challenge for us here is about measuring risk. Now, we could have decided to do as little as possible. We could have made the service smaller. We could have tried to retreat to our core essentials. But on a UK level, we decided that this actually wasn't the right time to be diluting standards, particularly as we'd launched an all-singing, all-dancing, multi-professional set of standards this year, which in many ways went under the radar for obvious reasons because of the change in the way that we practice because of the pandemic. But we felt if it was in this toolkit, if it was in these standards, it was still important and it should still be adopted. And we looked within it for things that helped monitor and assess risk. So risk is about a couple of things. There's about knowing what the risks are, and it's about communicating that risk. And that's really why this project has got two sides to it, both identifying and measuring risk and also communicating it as well as possible. So the first part of the project is about measuring risk. And for this, we've partnered up with SUDEP Action, who are an epilepsy bereavement charity and are pioneers both in supporting families and helping to discuss risk. And there are two tools that they've helped to design themselves in partnership with academics in Cornwall. One is really aimed at clinicians, and that's a checklist. So that's helping doctors and nurses to look at the risks that an individual may have. Now, some of those risks will be with you all throughout your life. Some will vary day by day or month by month. And that's what we'd call the checklist. And then there's a version which is app-based, and that's the Epsimon app. And that would help patients identify and monitor their risk as well. Now, there's this concept called social prescribing. Social prescribing is where you can prescribe something that's not a medicine. So it could be information or a diet or an exercise regime. And we're going to prescribe these two tools for our patients, all of them, rather than just cherry pick who we think who would be at increased risk of injury or death or something like that, we're going to give it to absolutely everybody who comes through our service with epilepsy and create a big cohort of information. In fact, we're not just going to apply it once, we're going to capture people on 2 occasions to see whether this risk is dynamic, whether it can be changed by self-monitoring. This has been done before, the checklists and the app are widely used, but what we're hoping to show is it can be done at scale and that this can be reproducible and that it helps to improve standard of care. So as I said, reproducible, scale, big numbers, and we're going to prescribe this to our Newcastle cohort of adults. So the second part of the project is about communicating risk. And for this, we're going to try and do 2 separate things. One is trying to communicate risk to people with epilepsy. And the second is helping clinicians who may not necessarily be epilepsy clinicians talk about risk. So the second part of that is really patients who go under the radar. Maybe they live chaotic lives, maybe they just don't need an epilepsy specialist from time to time, but they're more likely perhaps to see somebody who's a paramedic, see somebody in maternity services or drug and alcohol services. And there's a whole subset of people that we just never see, but who have active epilepsy. And I think they probably carry a greater risk than the cohort of patients who I do see on a regular basis. And so we're going to put together videos to help the paramedics, the maternity services, midwives, and drug and alcohol teams to help discuss risk with patients with epilepsy, because this might be the only time that they access healthcare systems. I think we can all take a responsibility for discussing risk, and it need not necessarily just be the small number of epilepsy specialists in the UK. We've got to make this look right, the right part, because it can't look like these old-fashioned whiteboarding male doctor in a white coat staring down the barrel of the lens, patronizing people. It can't be high cringe. We're really trying to have something that's not old-fashioned and is not creaky and speaks to really working age adults and without being patronizing. There are some great examples out there. Epilepsy Action, for example, have got some great videos for children transitioning into adult services, but they don't cover all the topics that we need, and we're hoping to put some of those together ourselves. So we've put together a team to manage this. Ella Akai is my consultant colleague here in Newcastle. She's going to be helping on both halves of the project. Mustafa Sultan is a digital native. He's a medical student who has expertise in putting together communication and video. He's going to be our consultant on the video part of the project. We've got fantastic charity partners with Seed Up Action, with Sammy and Jane here being worldwide experts in the communication of risk. And they're going to really help with the patient engagement and making sure that all the videos we put together don't just make sense to the clinicians, but to the target audience, the patients as well. Michael Norton is a community cardiologist. He works for the North East Ambulance Service, and he's going to help us make sure that our videos make sense outside of the epilepsy bubble. And Rohit Shankar is an expert in SUDEP and helped to create the checklist and the app. And so he's going to be a great asset to our team. So we've got 18 months, we've got to be busy, and we will return to you, our supporters, with evidence of all of these people receiving the checklist and the app, and in terms of what information we get from it, how dynamic their risk is, and whether it can be modified. We will have a couple of products, a couple of videos that we hope to be proud of that could be translated, subtitled, and disseminated to a wide audience. We'll hope to have some ideas in terms of what social prescribing for epilepsy looks like, and whether these videos could help with group consultations. This is a kind of a new idea within the NHS to sort of communicate ideas to people at scale. So this is my opportunity to once again thank you very much, not just to Epilepsy Research UK, but to their supporters for your support here. Thank you very much.
And thanks to all of you. Dr. Thomas, you said communication is so important, and I think that we've had some excellent presentations there that have really communicated very well the work that you've all been doing. I'd like now to welcome back all of the speakers who to take part in a roundtable discussion and to answer some of the questions that Epilepsy Research UK supporters have been sending into us. Also joining us will be Dr. Joe Ford, who's the conversation analyst from Professor Reuber's project. So welcome to you, Dr. Ford, as well. This is a sort of kick-off question. We've talked there obviously about the research and the projects that you've all been working on. We know that, and I'd love to get your perspective on this, we know that COVID-19 has interrupted everyone's lives in an unprecedented way. As clinicians, in what ways do you think the pandemic has interrupted the lives of people in particular who are living with epilepsy? And maybe Rhys, Dr. Thomas, if you could answer that one first, and I'll come to the others. Thank you.
Yeah, it's a whole number of ways, and because epilepsy affects lots of people in different ways, I think we've had a whole range. As Markus touched upon, there have been some people who have been overjoyed by the move to, telephone consults, by some of the innovation that we've had. We've had people who have been probably not served so well by the changes that we've had, and maybe some of the investigations have been slower this year. And then there's a group of people that concern me who may have been slower to ask for help for fear of disturbing what they consider to be busy NHS services, or people who don't have a good advocate or supporter at home, letting people know that they're in trouble. Because we know that there have been times of the year where we have been a little less busy than we would have expected to be. And so I'm concerned that there's a whole range of experience over the course of this year.
Absolutely. Sameer, what's been your experience of the way this pandemic has affected people's lives, particularly those with epilepsy?
I think people with established epilepsy and continuing seizures sometimes have been reluctant to attend hospital. So I think it's been really important that we have tried to build ways of communicating with them, so that so that they feel comfortable if they need to come up, or that they can communicate with their specialists without having to come up to the hospital. So it's giving families of our patients confidence. I think it's been difficult because we've done more remote consultations, and Markus will, I'm sure, talk about this. But some of the things that you don't get, when you first see a patient with epilepsy, you also want to be looking at the development of the child. The child may be in the room, but we want to watch how they're playing, how they're moving, and all the other comorbidities that go with epilepsy, all the other things. And sometimes they're more difficult to assess, over a telephone or over a video consultation.
Absolutely. And Markus, I guess a lot of your research has been your project is focused on exactly this problem. What's your perspective here?
I mean, I think the situation has changed quite a lot over the time that we've been dealing with the pandemic. Initially there was a lot of goodwill and motivation and enthusiasm on all sides to make it work, and people were amazed what could be done and how many people could be helped. But then, as frustration set in about the lockdown, people become a little more critical, and I think the concerns have grown. A lot of things have been parked, and that was okay for a while, but the longer it goes on for, the greater the concerns are that there is this somewhat lost group of patients who are not getting the services they need. Quite apart from people who were, for instance, undergoing epilepsy surgery evaluation and whose treatments have been stopped completely. So I think we do need to come out of this, although we have learned quite a number of good things that will stay with us and that will make things better for people in the future.
Absolutely. I mean, as you alluded to there, we have seen scientific research happening at an accelerated rate, and I think we're all glad to see the news that of the various vaccines that are now coming forward for COVID. But we've seen this research happen very fast when humanity is faced with such a problem like COVID. But why, in your view, doesn't epilepsy research seem to happen quite so fast? Maybe Markus, I'll turn to you for that first.
Well, there is a funding issue. So if you look at the number of people with epilepsy and the number of people with cancers, for instance, a number of people with Parkinson's disease, and you look at the proportion of research funding that is spent or available for epilepsy research, epilepsy is underserved. I think that then is caused by the stigma that still surrounds epilepsy and the difficulties people have talking about it. It also isn't easy to show epilepsy. If you are raising money for conditions that put in wheelchairs, you can have posters with wheelchairs, and or if you're collecting money that affect people, only children, then that's somehow often more palatable than the whole spectrum of epilepsy. So so there are some financial issues, and there's a stigma which pervades all aspects of epilepsy research, researchers, patients, and funding.
Rhys or Sameer, I don't know if you've got thoughts on that as well. Maybe Rhys, turn to you first.
I think it helped that we were uniquely motivated for COVID. I think everybody felt it affected them personally, whereupon there's a compassion gap between some people who don't have any experience of epilepsy and those people who do. And I think the question that we were asking of COVID was probably easier. It was a virus, and we knew that we had vaccines to viruses before. So shaping the research question and allowing us to focus upon one issue. Now, I'll be surprised if there's an epilepsy vaccine that's possible, but I'd love to hear about it. But we've got to plow parallel furrows to be able to treat all the different epilepsies. And I think it's a more complex question, really.
Absolutely. Sameer, I'd like to turn to you for the next question, and also bring the others in as well. But all three of you really have talked about projects that involve more remote consultations. Do you think those sorts of I think some of you alluded to this as well, but do you think those remote consultations are here to stay? How's that going to work practically when we all go back to being able to go to see GPs and go back to hospitals more easily? How do you think that these remote consultations will fit into the way that we do things in future?
I think we will do more remote consultations, particularly for our established patients. If you think of the difficulty of bringing a child who maybe has a movement problem, is in a wheelchair, has got learning disability, has got autism, bringing them to a hospital is a real challenge for families a lot of the time. So many families have preferred that, either the video consultation or telephone consultation when you know the family well, and you have that empathy with them. I think in the future we will have a mixture of maybe telephone, video consultations, and face-to-face. We need to continue to have face-to-face, and it probably is likely that most of our new patient appointments will go back to face-to-face, but we will have this mixture. I think, interestingly, sometimes, although we think about remote consultations, something I think like the Recreate Neuro app that we've built actually brings patients closer to us.
Yeah.
Because they feel closer to us, because they feel much more connected, because their child has a seizure, or they have a seizure and a family member takes a video of them. They can upload that, they can get a response quickly, they know that someone is looking at it, they can get a response through the system. So actually, new technologies may make us more connected rather than less connected to our patients.
Yeah, it's interesting, isn't it? I think that in some ways across working life, not just in the areas that the three of you are talking about, obviously the pandemic may have accelerated changes in the way we work, changes in the way we do events such as this, of course. But Rhys, I'd like to turn back to you on this, actually. I mean, the sort of project that you're working on, and the introduction of apps and checklists and so on, do you think that this period that we've been through, almost a year now, has really changed behavior in a way that will encourage people to use apps even more than maybe they did in the past?
Yeah, I think it's an opportunity. I don't really know how it's changed behavior, but it has changed so many things. And up until now, we in the NHS had almost got used to the fact that things were hard to change. It was hard to make a change. It was hard to bring in a new service. And then within a couple of weeks, we went to telephone consults overnight without any red tape. We just went there. and there were blocks that were previously preventing us from doing it, and suddenly we had video consultation software available to us. So I think it has allowed us to be optimistic and be a bit braver, and to think about what's the best service that we can put together, accepting the fact that there are some limitations. We don't have enough neurologists, epilepsy specialist nurses, epilepsy specialists, and so therefore self-management is an attractive strategy.
And Markus, your thoughts on this area, remote consultations, and the work you've been doing on analysing how those take place. Do you think it's all here to stay?
Well, I think that the relationship that patients have, or some patients have with the doctors, those that are able to access modern means of communication like email, are comfortable with that, those relationships have changed permanently. I get more emails by a factor of 10 now than I did 2 years ago. And much of this change has come about because of COVID and the telephone consultations. So this is good and bad. It has reduced the barriers. The problem there is my limited time, and that this increases stress for people with limited resources. Our epilepsy nurses have noticed the same thing, and the nursing pool has been considerably diminished by illness. I've been fortunate; I've not been ill, but so there's been quite a lot of stress. But in principle, the reduction of the barrier is good. One problem is that this is good for that group of people who can use it, and especially in people with epilepsy, you've got considerably large, sizable groups of people who will not use this. All the elderly people with epilepsy who think, oh, I can't bother the doctor because they're busy, people with learning disabilities and epilepsy. So there are some populations who miss out on this, and who could be squashed out, by the increased workload that is generated by reducing the barrier. So I think it unfortunately calls for more services and cleverer ways of using the services that we have. The resources that we have.
Pros and cons, but it's interesting how COVID has catalyzed some of these ideas and thoughts. I wanted to ask each of you as well how the results of your research will be used, and whether they'll be shared around the UK to innovate services for people with epilepsy nationwide. Maybe Sameer, I'll start with you on that, because I think your initial focus has been on Scotland and the north of England, but how's that going to sort of spread through the UK, do you think?
Yeah, so the system itself is spreading through the UK. So it's in Evelina Hospital now, Great Ormond Street, Sheffield Children's, Hull, Manchester, Oxford, and Newcastle as well.
Right.
Here. So it's spreading, and we haven't advertised it at all. It's just become through word of mouth. So I think it is. And in fact, I'm speaking to a doctor in Tunisia, and the World Health Organization are interested in this as well because of its ability, maybe internationally, in remote parts of the world. So I think the system will spread, and I think the research that we're able to do with Epilepsy Research UK will show us how effective it is.
Yeah.
And then if it's as effective as we think it is as doctors, but then we can really demonstrate it to funders and to colleagues, around the UK and around the world. This is how we should be interacting, or one aspect of interaction with our patients.
Absolutely. Markus, your work and spreading it through the UK?
Well, I can give you an example. Maybe Joe can think of some additional ones, but this is not directly answering your question, but it shows you what this apparently complicated conversation analysis can do. So there's a study where they got people to write down all the things they wanted to talk to the doctor about before they got to see the doctor. And on average, people had 4 or 5 items that they wanted to discuss with the doctor. And then they did the conversation analysis to count how many items they discussed. And usually it was 1 or 2. And then people were randomized. So a lot decided whether the doctor would, at the end of the consultation, ask them, is there anything else you want to talk about today? Or is there something else you want to talk about today? Those were the 2 options, anything, something. And the question, is there anything else that you want to talk about today? it generated no extra items. No, although 2 or 3 items had never been touched on, the question, is there anything else? It makes it more likely that you'll say no. And people did say no, and they left the room because they realized the doctor said goodbye, essentially. Whereas the question, is there something else you want to do to discuss with me today? That doubled the number of items that had been covered. People did say, well, actually, there was one other thing. So that's a practical and very simple lesson that doctors can draw from conversation analysis, not just in England, elsewhere too.
Right, absolutely.
Maybe have you got some additional examples of what conversation analysis can do?
No, I think you took my best example, but just to expand on that, yeah, I mean, it's not just some any, it's the distinction between a question which has a negative expectation in it versus a question which has a positive expectation, expectation for a negative response, expectation for a positive response embedded in it. So some and any are 2 of the ways that can be done, but there are all sorts of ways in which questions can be changed to be more effective.
Yeah, it's fascinating. Once you start thinking about it, there's so many ways that we communicate that lead to certain outcomes. Rhys, your thoughts on this area and making this a sort of national project?
Yeah, a couple of examples. I mean, if we look at in terms of the media people consume, the 3rd biggest television channel is YouTube, and so we've got to have as big a video presence as we can there in terms of the communication that we make, and I think if it's deemed to be a success, it's very easily translated into other languages with subtitles, and it's the product we can either export in that way or help other people piece together with translators to make it as reproducible as possible. And then with regards to the first part of the project, there's nothing particularly exceptional about Newcastle. We're a medium-sized neuroscience centre in a normal part of the world, so if it can be done here, it can be done anywhere.
Yeah, I'm sure Newcastle is exceptional in its way. I hope I've left enough time to go back to Caoimhe now. She's been collecting some questions submitted by the audience. So Caoimhe, if you want to take over with those now.
Hi, yes, thank you. We've had some brilliant comments and questions from the audience. One of the comments that were mentioned was that how beneficial remote consultations could be, particularly for people with epilepsy who are unable to drive, which is obviously a huge concern for many people living with epilepsy and with uncontrolled seizures. One question that we've had from Angie from Epilepsy Action, who is obviously the co-funder of Markus's study. Sameer, could your study, could this replace some of the need for video telemetry and hospital admission?
It won't replace it completely, but I think it will reduce the need for video telemetry and hospital admission. It's certainly done that for us, because you see the video and you realize that it's definitely epileptic if the question is this epileptic or not, or it's definitely non-epileptic. And if you're an experienced epileptologist and you discuss with colleagues, most of the time you can tell. Sometimes it's difficult. So it definitely does reduce the number of EEGs that we need to do. The other thing that it's done, I think, we perceive this, but again, your funding hopefully will allow us to really test, is we think we're prescribing less medication, because we get people asking us, this person with epilepsy, their seizures have increased, could you, we need to increase the medicine. We get the video and we see that person does have epilepsy, but the new event is not an epileptic seizure. And therefore we don't need to increase the anti-epileptic medication. So I think that is another, potential benefit of things that we won't have to do.
Fantastic. So it could reduce some of the burden on the NHS potentially. That's brilliant. And so we've had another question from Moira in Wales, and this is for both Joe and Markus. How will you manage for people for whom English is not their first language?
Maybe Joe can go first.
I think the important thing to think when it comes to the conversation analytic approach is really that we're not looking at a particular language, we're looking at the structure of conversation. And all of the evidence that's been gathered so far is that conversational structure is universal. So obviously you have to, as an analyst, you have to make certain changes in your approach, perhaps if you are looking at a case where the patient doesn't speak English as a first language. But fundamentally, the approach and the approach that's taken to the conversational structure remains unchanged.
Yes, and I mean, there would be a particular risk, of course, of misunderstandings, which might be particularly crass and obvious if you're dealing with a conversation with somebody whose first language is not English. So we might even learn from those interactions where the conversation happens in English, but the risk of misunderstanding is particularly high. That might alert us to how those misunderstandings can be picked up in conversations between people whose first language is English. In real life, of course, that's something I haven't mentioned, wasn't on my photographs. We use interpreting organizations now. So it is horrendously complicated to speak to people who don't speak English at all. You know, I have to ring a company, say what language I want. I give them the telephone number of the patient, and they then phone the patient and are on the line with me and the patient. It really isn't good at all. If you have a face-to-face interpreter, you can talk to the patient, look at the patient as if you were talking to the patient in a language they can understand, and the interpreter sits out of the field of vision and interprets. On the phone, that isn't possible at all. So it really diminishes consultations. But I think, I'm not sure whether we capture those sorts of consultations. The other ones, where English is the medium, will be interesting, regardless of whether everybody is a first English speaker.
Of course. And then the final question from the audience is for Rhys. So how are you involving young people with epilepsy in the development of the videos that you mentioned?
Yeah, so we are aiming the videos at adults rather than people at sort of transition age or younger, because they're the people that we see in our clinic. And our patient engagement group is through SUDEP Action. And so they have both people with epilepsy and people whose lives have been affected because they've lost somebody associated with epilepsy, and they're our group here. So they're often sisters, brothers, partners, and so we've got a range of predominantly working age adults who are helping. And as I said, Mustafa Sultan is our digital native. He's in his early 20s and helps us to avoid the high cringe of producing a NAF product.
Thank you, Rhys. That's all the questions from the audience. So back to you, Andrew.
Well, thank you, Caoimhe, and thanks for those excellent questions. Just a final question to all of you, really, just to round things up. What are your hopes for the future research into epilepsy, and your hopes for people who are living with epilepsy? Markus, if I come to you first on that, please.
Well, I do hope that we will learn how to select those patients who can safely benefit from remote consultations, because it's much easier for them on a bigger scale. I hope that what we've learned about mRNA vaccines will actually be useful as an epilepsy treatment. It's not inconceivable.
Really, that sounds like another webinar to come. That's very interesting. Sameer, your thoughts on that, please? Yeah,
my hopes are that people will support epilepsy research. That I think one of the challenges is that there is a lack of empathy for people with epilepsy. And that's one of the challenges, and that, you know, we can get funding from Epilepsy Research UK, but we need to be getting funding from the big research councils as well. So Epilepsy Research UK has a wonderful role in providing grants, which then can help us get to that next level. And it's getting to that next level, which is a real challenge, I think, for epilepsy researchers. So I hope that the world of that governments will realize that neurological disorders are provide the greatest burden for society moving forwards, and that includes epilepsy. And I think there is an increasing awareness of that, and hopefully with that, more funding will come for epilepsy research.
Yeah, absolutely. Rhys, some final thoughts there from you as well, please.
Yeah, I'll follow on from what Sameer was saying. I mean, they call Newcastle United a sleeping giant. It's a club with a great potential, and I think epilepsy has that too. We've got a big supporter base. You know, people with epilepsy and people's lives have been affected because they know somebody with epilepsy, and I think making the most of that patient voice through initiatives like the Epilepsy Research UK SHAPE network to help with better patient engagement, to help with, and also to help make sure that standards in the best of centres are there in all centres. You know, they say the future's already here, it's just not evenly distributed. And if we could do the best for people with epilepsy in all parts of the UK and beyond, I think we'd be doing a great job.
Well, those are inspirational thoughts, really, that you've all finished with there. And I want to congratulate all three of you again, and Joe, of course, for the work that you've been doing and for the awards that you've been granted, that we've been celebrating this evening. And thank you so much for sharing your expertise so clearly and so engagingly over the last hour or so. I've learned a huge amount once again from taking part. With that, I'd like to hand back to Caoimhe.
Thank you so much, Andrew, for hosting the webinar this evening, and to all of our panelists for these fascinating presentations and discussions. I think we're all really looking forward to seeing how these research projects will impact people living with epilepsy in the quite near future as well, I think. And each of these researchers has written a research blog for us, which will be shared on our website and social media throughout the month of December. This week we had Markus's blog, so you can visit our website to hear more from Markus on that. I know Rhys, well, actually all of our researchers mentioned the lack of investment in epilepsy research, and so if you're interested in reading more about that, you may be interested in reading our report that we released when we launched the A Life Interrupted campaign. It's called Shaping the Future of Research into Epilepsy, and that details just how underfunded research into epilepsy is. So a huge thank you to all of our panelists. Thanks also to my colleague James Mataika, who has been busy behind the scenes ensuring that all of our tech runs smoothly. And a huge thank you to all of you for joining us this evening and watching the webinar, submitting your questions. We also wanted to say a special thank you to those of you who have already signed up to our SHAPE Epilepsy Research Network that I think Rhys mentioned there. We've just been bowled over by the responses that we've received. And if your life has been interrupted by epilepsy and you haven't yet joined the SHAPE network, why not put it on your to-do list for this weekend? We'll have the details on screen just in a moment. This will be our last webinar of 2020, so we look forward to seeing you all again in the new year. And until then, have a great festive break. And thank you again to all of our panelists, to Andrew, and to all of you watching.